Thank you, Dr. Saket, and thank you to all the chairpersons. Now we'll come to the next session, the role of therapeutic procedures and surgical interventions in obesity. Uh, Before that, I would like to invite the chairpersons on stage. I would invite Dr. Naresh Aggarwal, Dr. Vaishali Bhardwaj, Dr. Vibhu Mittal, Dr. KGS Narula, and Dr. SK Gupta. May I have all the chairpersons on stage, and I would request Dr. Naresh Aggarwal to kindly introduce the two speakers to the audience.
Good evening, ladies and gentlemen. This session is last but not the least, simply because after all these learnings, many of your valuable patients will require this session, endoscopic or surgical. So very important. I welcome all chairpersons. Sir, please. And our first speaker, our first session is on endoscopic bariatric, and eminent speaker Dr. Yogesh Batra is there. He is a senior consultant at Indraprastha Apollo Hospital. He is DM from All India Institute of Medical Sciences. I'll welcome Dr. Yogesh Batra for his lecture. Thank you so much.
Thank you, Naresh, for that kind introduction. My talk today is to talk about bariatric endoscopy. I think there would be about 60% people in this room who have been trying to reduce weight. And out of these 60%, I think 40% would have failed. We have had talks since the morning about medical management, about diet, about nutrition. And I would not go into all that, but what we have actually learned is that lifestyle modification can only result in weight loss to about 5%. If you add medical management, it goes to about 10%. If you really want drastic weight reduction, then you have to think of surgery. Dr. Vivek would be talking about that in the next talk. So in between the medical management and surgery, there is this vast spectrum of patients who need weight loss and who don't know what to do and where to go. So first of all, we need to accept that the time has come for us to accept these devices for weight loss. We have not been very forthcoming in accepting them, and we do not advise patients that they should actually go ahead and get a gastric balloon or a gastric sleeve done. Gastroenterologists are likely to see more patients requiring weight reduction than any other specialty, and the reason is that whether it is esophageal disease, is it disease of the stomach, colorectal disease, or various GI cancers, the first point of contact is going to be the gastroenterologist. We are also endoscopists, so we are the ones who are going to treat these patients, and probably in future the specialty of endobariatrics is going to come up and grow. While researching for this talk, I also found that there are not much of guidelines available, but at the same time I found this phenomenal paper from Brazil, in which, since this was published in 2016, and they had already put in about 40,000 gastric balloons till 2016 in all of Brazil. I don't think that we put combined in all of Delhi or all of NCR, we put more than 20 or 30 in a year. When we talk about gastric balloons, I would be talking about the indications, contraindications, mechanism of action, types of balloon, results, and which balloon to use. There are no clear-cut guideline-mediated indications for a gastric balloon, but a gastric balloon is to be put if a BMI of a patient is 30 to 40, he has failed, tried and failed lifestyle changes, is not a candidate for surgery or is not willing for surgery, or as a bridge to surgery. I mean, somebody has CKD, he cannot be taken up for surgery straight away. You put in a balloon, reduce its weight, make him fit enough so that he can undergo surgery. There are other indications, like for example, we have a lot of transplant donors who have NASH. So they have to be brought down and made fit enough so that they can donate their livers. So you put in a balloon, and within a month or two, the NASH comes down, the liver enzyme normalize, you repeat a biopsy, see that the fat content has come down, they can be taken up for surgery. What are the contraindications for gastric balloons? So there are absolute contraindications and there are relative contraindications. Absolute contraindications for a balloon would be gastric, duodenal or esophageal ulcers, because balloons themselves can result in ulcers, and if there is a pre-existing ulcer, it can lead to a bleed. Esophageal or gastric varices, a hiatal hernia more than 5 centimeters, because the balloon can go and lodge in that hiatal and then can cause esophageal perforation. Coagulopathy, because balloons have a tendency to cause bleeding. If there is already coagulopathy, then this can worsen. The relative contraindications are gastric angioectasias, eosinophilic esophagitis, immunocompetent HIV positive patients, and uncontrolled, untreated psychiatric patients. How does an intragastric balloon cause weight loss? So obviously it reduces space in the stomach and causes early satiety. It delays gastric emptying by blocking the pylorus, so the food stays in the stomach for a longer period of time. It reduces the secretion of ghrelin and cholecystokinin, and this results in more satiety. Now there are various types of intragastric balloons. So there are balloons which can be placed endoscopically or they can be swallowed. The ones which are swallowed are the obolon and the alluron balloon. Balloons can be saline filled or they can be gas filled. The gas filled again is the obolon. Obolon incidentally is not available in India. Single versus multiple. So reshape and obolon are multiple balloons. Obolon, in fact, you can go on having one balloon every month. So 3-4 balloons can be taken up. Non-adjustable versus adjustable balloons. So by adjustable balloon, we mean that you put in 400 ml of saline in a balloon, and once you are sure that the patient has tolerated the balloon well, you bring up the nozzle and you inject another 200 ml of saline to cause more weight loss. Most balloons have to be retrieved endoscopically. This new balloon disintegrates by itself. So after 4 months, you don't need to bring out the alluron balloon, and it disintegrates and passes through the intestine into the stool. This is what the balloons look like in the stomach. So this is the reshaped balloon. This has been taken off now. Orbera is the first balloon and possibly the most commonly used balloon, and about more than 3 lakh Orbera balloons have been put worldwide. Obolon is a gas-filled balloon. Multiple balloons can be placed in the stomach. Spats is the most commonly used balloon in India, and it has a nozzle here which can be brought up through the esophagus for readjustment. Ellipse, the alluron balloon used to be known as ellipse earlier. It is known as alluron now. It is a one-time placement. You swallow the balloon. It is not placed endoscopically. And transpyloric shuttle is classically not a gastric balloon. So balloon insertion can be endoscope guided or they have to be swallowed. And this is how you place a balloon. So this is an endoscope going into the stomach, and now the gastric balloon is being released into the stomach. It occupies at least 1/3 of the stomach, and it causes a sensation of early satiety because that much of food cannot be occupied in the stomach. And once the balloon has been there for 6 months, you puncture it with a needle and a suction catheter to remove all the liquid, and then you catch hold of this balloon with a grasper and remove it. So which are the balloons available in India and which one to choose? The three main balloons which are available in our country are Orbera, Spats and Aileron. Orbera and Spats have to be placed endoscopically, while Aileron is to be swallowed. It is like a pill, a large capsule which you swallow, and behind that is a catheter which then is used to fill it with saline. And once it is filled with saline, you simply pull the catheter and the attachment of the catheter seals. Duration for which the balloons can be put, so Orbera can be put for 6 months, Spats for 12 months and Aileron for 4 months. Obviously, the more the balloon is in place, the more likely to be the weight loss. Are they adjustable? Only Spats is adjustable. You have this tube here which can, this can be caught with the endoscope, brought out into the esophagus, and you can either remove saline or you can put in more saline. Amount of saline needed 400 to 700 for Orbera, 400 to 700 for Spats and 550 ml for Aileron. Cost. So Orbera costs 1.25 lakhs. This is the MRP as told to me by the distributor. Spats is 1.58 lakhs and Aileron today is 3.5 lakhs. Weight loss is similar in all the three balloons, so 10 to 15% weight loss in all three. Adverse events possibly are the least in Aileron. The other two have an adverse event of about 5 to 10%. Overall results with balloon. So this is the large Brazilian study which I was talking about, and they have shown that a total body weight loss of about 18 to 4%, varying from a minimum loss of 13% to a maximum loss of 25%. In terms of kgs, up to 18% loss was reported, from 12.5 to 32%. However, it is not that balloons are always successful, balloons also fail. So about 8.3% of patients, despite having balloons, failed. Balloons can have a number of side effects. I mean, putting in a balloon is not like getting an ultrasound done. It is a therapeutic procedure. It can result in side effects, and the side effects can be the balloon can hyperinflate. The mechanism of this hyperinflation is thought to be fungal infection of the balloon. There can be spontaneous deflation of the balloon. That is why once you put in saline, it is mixed with methylene blue so that the urine turns green or blue, and you get to know that the balloon has deflated. You need to go in and take this balloon out. They can migrate into the duodenum and into the intestine if they are not filled in properly. They can cause ulceration, bleeding, but what we are really worried about is perforation of the esophagus and perforation of the stomach. Deaths have been reported with balloons. These deaths are usually because of perforation, and they are more at the time of removal rather than at the time of putting in the balloon. So balloons are a temporary device. What happens after you remove the balloon? Balloons are there for 6 months or for 12 months. Once you remove the balloon, only 50% maintain weight loss at 1 year and 25% at 5 years. So it is not that you have put in a balloon and everything gets cured. Obviously, it does not. So basically, putting in a balloon is a period in which you have to train your patient to lifestyle changes. So the options to maintain weight are intensive lifestyle and behavioral therapy. Pharmacotherapy. Semaglutide is something which is very, very exciting, and semaglutide plus balloon has been shown to have excellent results. You can put in another balloon. Some people say that the next balloon should not be put in immediately. Some say that you can put in sequential balloons. You remove one, put in another one. There is no clear-cut consensus on this. Or if the patient is fitting the criteria, he can be taken up for bariatric surgery. So much about balloons. Coming to endoscopic sleeve gastroplasty. This is the second most established endoscopic indication for bariatrics. This is done by the Apollo overswitch endoscopy suturing system. So what you do is, like the surgical sleeve in which this much of the stomach is cut off and stapled, here you apply sutures to the greater curvature, and the entire stomach then forms a tube. It is done by this device here. It has a needle driver, suture anchor and handle to transfer the suture. So the endoscope goes inside the stomach. You mark the greater curve on the areas where you will take the sutures. This is usually done by organ plasma coagulation or APC. And then with the device, you start suturing the stomach by taking full thickness sutures from three areas. And then once these sutures are taken, you pull the suture and you close it down, and simply you go on doing this till the entire stomach is become a tube. Again, excellent results. So up to 19-20% weight loss reported with the endoscopic device. But the main thing is that it is almost side effect free. So mild side effects, mild complications like nausea, pain, abdomen reported. But serious side effects like pneumoperitoneum, bleed or perigastric leak are very, very low, up to about 1 to 2%. What about what about endoscopic versus laparoscopic sleeve gastrectomy? So although endoscopic sleeve gastrectomy has a lower weight loss compared to laparoscopic sleeve gastrectomy at 1 year, however, the adverse events are very, very low, and this probably makes it a better choice than a laparoscopic sleeve gastrectomy. I think Dr. Bindal would differ on this, but let's see what he says. Coming to other restrictive devices, so pyloric shuttle. This is a large gastric ball which stays in the pylorus, and another smaller ball which stays in the duodenum. This is something which is very, very astounding. I could not believe that there could be such a device. So this is like a PEG tube. A PEG tube is a feeding tube which we put in the stomach, and one end of the feeding tube is brought out to the skin, and there is a tap here. So you eat to your heart's content, and after you have eaten, about an hour later, you simply go down to the lavatory and you open the tap, and all the food comes out. So I thought this was some crazy thing, but surprisingly it has got excellent results. So at 4 years, about 20% weight loss has been reported by this device, and a lot of people in the US actually like this because they can eat as much as they want. So these were restricting devices, which means that they reduce the size of the stomach. Now coming to malabsorptive devices. Malabsorptive devices mean that they do not let the food be absorbed from the intestine. So this is the duodenojejunal sleeve. It is anchored into the duodenum at the pylorus and goes right into the jejunum. So whatever food comes here is not absorbed at all and goes out unabsorbed, undigested. So it does not cause obesity. So this is placed endoscopically. Again, good results. The best part about malabsorptive devices is that it affects diabetes and NAFLD more, and it has a good effect on these diseases. A modification of the sleeve now is the duodenojejunal sleeve, which means, gastroduodenojejunal sleeve, which means that the upper end of the sleeve is attached to a G junction, and then it goes through the duodenum into the jejunum. So whatever food is coming in does not enter the stomach at all. It passes directly through the tube across into the jejunum. So obviously better results, but it is more difficult to tolerate this tube. Again, an extremely interesting thing, I have seen it in a workshop, has not been used extensively, but a very, very interesting concept. That is, you use two endoscopes simultaneously. With one endoscope, you enter the stomach and enter the jejunum. With the other endoscope, you enter the colon and then you enter the ileum. And that part of the jejunum and ileum which are in close proximation, by the light of the endoscope, you place octagonal magnets. These magnets result in erosion of the wall between the jejunum and the ileal, so you create a jejuno-ileal bypass. This is an endoscopic jejuno-ileal bypass, and some of the food then goes through the bypass, the rest of the food goes through the normal path. So it's a partial bypass, it's not a complete bypass, and because it is a partial bypass, it does not result in diarrhea, it just results in weight loss. This is a FDA approved technology and again results in a weight loss of about 15% at 1 year. Again something very interesting, and that is a duodenal resurfacing. So this is a bag which causes thermal injury of the duodenum, as this contains heated water. You ablate the entire duodenum. Why? Because the concept is that the endocrine cells which are responsible for weight loss, the GLP-1 cells and the other neuroendocrine cells, are located in the first and second part of the duodenum. So if you are able to ablate the surface of the duodenum, you will be able to reset the entire duodenal mucosa and you would prevent obesity. This is the Revita device and it is yet not FDA approved. So coming to the end of the talk, finally, this is what the future is going to look. So you start with diet and exercise, and if that fails, you move over to weight loss medication, probably semaglutide or one of the more potent ones which are coming in future. If this fails, you go over to the intragastric balloon. If intragastric balloon also does not work, then you add intragastric balloon and weight loss medication. The next step after that would be endoscopic sleeve gastrectomy. Just finishing. After endoscopic sleeve gastrectomy, you can add an endoscopic sleeve gastrectomy plus weight loss medication. Finally, bariatric surgery plus weight loss medication. Thank you very much for a patient hearing.
I congratulate sir for a very lucid and exhaustive talk. Questions now? Or
Dr. Vaishali is head of the department from RML Hospital in the Department of Gastroenterology and is our GB Pant alumni. She wants to come.
So very nice and interesting talk. So much for weight loss, for food. So, what are your results with balloons at your center? Your personal recommendation. Which one will you choose?
Aileron is very, very new. So between Orbera and SPATS, results are similar. You can choose either of them. Side effects, complications are similar. The advantage with SPATS is that you can start slow and you can actually build it up. So probably SPATS has an edge over Orbera.
So how many needs reballooning after a year or something? How is your experience with reballooning? After a year, after removal, do you insert again?
I have had 2 patients in which I have done it. I am not a very ardent follower of reballooning. I would rather go in for pharmacotherapy and weight loss by other methods.
Any short comments from the audience? Right, so Dr.
1 year for SPATS, 6 months for Orbera and 4 months for Aileron. That is the first time. If you want to do reballooning, you can go on as long as you want. There is no guideline on that.
Dr. Vibhu, anything? So thank you, Yogesh sir.
Thank you.
for a comprehensive talk. And next speaker is eminent bariatric surgeon, Dr.